Good morning, everyone, and welcome to today's webinar, Beyond Wellness, Effectively Managing Chronic Conditions. I'm Jenna Westenberg with HealthCheck 360. We have a great presentation for you today, but before we get started, I'd like to take care of a few housekeeping items. We will have some time for questions at the end of the presentation. If you have any questions, please type them into the question box in the lower portion of the control panel. We will also be posting a recording of the webinar online, so if you'd like to replay this presentation at a later date, it will be available. Also, if anyone would like a copy of the presentation, please send an email to me or type your request in the question box. Today we have Chris Lambert and Jessica Mandot with us to talk a little bit about how you can go beyond your wellness program and effectively manage those chronic conditions, improving on the disease management programs of today. Now I'll turn the presentation over to Jessica.
Thank you, Jenna. When we were talking internally about kind of what we wanted this webinar to be leading into the fall and the busy season that I know you all have coming up, we really were thinking about a lot of the conversations that we've had with employer groups, brokers across the country, and have received a lot of feedback and skepticism on the effectiveness and impact of standard or traditional disease management programs. And at HealthCheck 360, we're continuously trying to be innovative and create new services really that are going to be effective and impactful for our clients. And so what we wanted to talk through today was really just some of the approaches that we have for our disease management or compliance management that we might reference it that way today. So share our new approach, kind of best practices that we have with that, and the successes that our clients are seeing working with us in the disease management space. So as far as an agenda for today, walking through the current employer views on disease management, looking at the shortcomings of the traditional or standard disease management programs that the industry sees today, benefits of integrating the wellness program with condition management, so really what that program should look like, the best practices, and why the program should be integrated with your disease management. And then we have a case study to show you the successes that, like I said, our clients are seeing with it having an integrated approach. So first, the current employer views on disease management. So looking at a Mercer study on their annual study of large employers, they're showing that 80% of companies are still purchasing disease management, and it's been pretty much consistent over the last 4 or 5 years or so. But ironically, very few are rating their disease management program as very effective, and you'll see that, through this graph, this is through the Kaiser Family Foundation survey, less than 20% of employers are happy or very satisfied with the effectiveness of their disease management program. And like I said, that's been a decline over the last few years. So we really wanted to look at, what are some of the best practices that we can implement with clients that are going to show a more effective rate of engagement, rate of compliance, and overall return on investment for groups. This information here is from the RAND report that was put out a couple of years ago. But essentially, research is showing that return on investment for disease management is about double what you see in a lifestyle management or a wellness program. And a lot of that is because disease management can have an impact a lot faster than what you might see for a wellness program. So if you think about looking at your employees or a group in 3 different ways. 1, you have the healthy individuals. Number 2, you've got the high-risk people that potentially don't have a chronic condition. And then 3, you have the individuals that do have a current chronic condition. And so for disease management, you can have a high impact almost immediately by helping individuals to manage those chronic conditions, because you're preventing them from having a high-cost claim in 18 months from now. So if I'm a diabetic and I'm not compliant with care, I have an A1C of 12, and my average glucose levels fasting are over 400, that's a catastrophic claim that's waiting to happen, at any moment. But if you put in an approach that's going to effectively help them understand what it means to be a diabetic and complete the care items that their doctor recommends and the American Diabetes Association recommends, then you're going to help that person have an impact almost immediately by managing that care. Whereas lifestyle management programs, like I said, it's more of a long-term effect. We're putting money in to help the healthy people stay healthy as they age, as well as help individuals that are in high-risk categories mitigate those risks and prevent them from becoming a chronic condition. So it's a little bit of a long-term effect, but it's important to have both approaches, right? Because having an integrated approach, we're going to keep the healthy people healthy, we're going to target the high-risk individuals, help them reduce those risks, and then we're going to help the individuals that have a chronic condition to be compliant with care and impact claims immediately as well as long-term. So looking at some of the shortcomings of a traditional disease wellness program. So we've kind of categorized these in 3 different ways. One, traditional programs look at claims data and predictive modeling tools and don't really look at any biometric data, and I'll kind of get into these in a little bit more detail. The second reason is lack of incentive. So because very few companies are putting in meaningful incentives to drive compliance rates, we're seeing that the participation, engagement, and compliance in disease management programs are very low. And third, we're reporting on the wrong metrics. So it's kind of funny when you ask to see reporting on the disease management programs that clients have in place, and they're really looking at the wrong metrics to determine success of that program. So looking specifically at claims data versus biometric data. So like I mentioned, most traditional disease management programs are just looking at claims to identify people into the DM programs. So essentially they're looking in the rearview mirror. They're looking at what's previously happened, who's incurring these claims, versus proactively identifying people that are unaware that they have a condition or aren't incurring claims, know they have a condition, and aren't effectively managing it. So this is one of our clients that we basically look to see if disease management and an integrated solution would be a good fit for them. It's about a 2,000 life manufacturing group, and when we looked at their claims, they had only 50 claims suggesting diabetes or prediabetes. So only 50 people showed up on the DM radar of people being identified for diabetes management. When we looked at their biometric data, we had 111 people that fell into high-risk glucose ranges or diabetic glucose ranges, and we had 580 people in pre-diabetic ranges. You can see kind of a similar story with hypertension and with some of the heart disease. 78 people had claims suggesting hypertension, when in reality we had 549 people with elevated blood pressure readings. So essentially what that's telling us is that the claims are only looking at a subgroup of individuals, and in order to be effective in our disease management, we need to target people that are not showing up on claims. And those are almost the scary people, because they either don't know that they have a condition and so they don't know that something's wrong, or they know something's wrong and they're not doing anything to manage it. So a successful program is going to integrate claims and biometric data. The second one is the lack of incentives to drive participation. So what the graph on the top left is showing is the participation rate, so employee participation in disease management programs. And so 65% of employers with a disease management program had 0 to 20% participation rate in that disease management program. Less than 1% of employers had a participation rate above 60%. So what you're seeing is that employers have these, 80% of employers have a disease management program, but less than 20% of people identified in the program are participating or engaging in it. And that's just looking at engagement rates, not compliance rates within the program. And the other thing we wanted to look at was the incentives for these types of lifestyle management programs. And you can see a little less than 70% of employers offer an incentive to participate in a wellness program, but less than 4% offer an incentive for participating in disease management. So again, kind of a interesting fact there that we don't see as much engagement, but yet this can have an even bigger impact on return on investment than the lifestyle management program. And then the third piece is reporting on the wrong metrics. So this is a sample of some of the reporting that the carriers provide and the traditional disease management programs provide. And everything that you see on here is looking at the outreaches that they have made to the employees. And so if you look at asthma, the first disease on there, you can see how many unique individuals they have, and it shows how many were unreached, how many were active, participating, how many had 1 call, 2 calls, and so on and so forth. But nowhere on here does it share with us the impact that this program is having on their employees. What percentage are compliant with their care? What percentage have improved their A1C or reduced claims potentially because of disease management? And so we're really looking at the wrong metrics on here because we're looking at call activity. Basically for the disease management company to tell the client, yes, we're doing what we're supposed to be doing in terms of outreach. But at the end of the day, this isn't telling a client the impact that their program's having on their population. So I'm going to hand it over to Chris Lambert to get into the nitty-gritty specifics of the HealthCheck 360 disease management program.
Great. Thanks, Jess, and thank you everybody for being on the call with us today. I appreciate your time. So let's go ahead and we'll dive into some of the specifics. So our approach is really focused on 4 key components. We drive decision-making based on our data. We integrate between claims, biometric wellness, and chronic care, and we think that's a key distinction because in typical scenarios with disease management, you're going to see those in a siloed environment. We also base our approach on adherence with evidence-based care recommendations and with medication adherence. And so we do calculate a med possession ratio for each of our members in the chronic care categories. And then we're targeting the RN engagement, those expensive resources, to the members who need intervention, and then also marrying up the skill set of the registered nurse with the need of the member as well. And we'll get into more detail on each of these points. So the first step for us really is to identify who the right mix of members is. On the left-hand side, what we're doing is we're utilizing our analytics tool. We license an Optum product for predictive modeling, and we feed in paid medical claims and paid pharmacy claims to get that first roster of enrollment. And these are the folks that Jess referred to as being identified in claims. So again, a piece of the picture. And then we marry that up with the HRA biometrics, which we know are important, not only because we're identifying those undiagnosed members, but also we're identifying those folks who perhaps are so non-compliant that they've fallen off of the claims radar. And we're also utilizing it to stratify our members further for additional engagement with an RN. So medical claims may tell me I have an A1C, but it doesn't give me the actual result. The biometrics will. I may know someone had a hypertension office visit, but now I also have a recent blood pressure measurement. So the HRA biometrics are really key to everything that we do in our department. We will ask for new clients for 12 months of medical claims and PBM data, as well as the most recent health risk assessment. And because of our integration, we'll go out actually and we'll just grab that out of the HealthCheck 360 system. So the conditions that we target all have a high self-management component. In the respiratory bucket, we do asthma and COPD. Asthma is slightly different from the other condition in that, yes, we do look at annual recommended care and med adherence, but we're also trying to drive those members out of the ER for their routine care. We want them engaged with their primary care providers and not relying on episodic care in the ER when they have a flare. We also work with the diabetic bucket, heart failure, and then under the umbrella of coronary artery disease, we work with individuals who have high blood pressure or hypertension, hyperlipidemia, or high cholesterol, and then those folks who already have known coronary disease under the heading of ischemic heart disease, so perhaps somebody with a history of heart attack or chest pain. We also customize the roster of programs to the client. So some of our companies may do 2 conditions, they may do all 7 conditions, and we're going to be using our analytics to go in and really dig into the medical claims, into the last several HRAs to make a recommendation on what that mix should be for their population. And then we also adjust sometimes at mid-year. So for example, if a company starts out with asthma, diabetes, and hypertension, once we get a new HRA in, we may switch out asthma for high cholesterol or another condition. But again, this is an ongoing process of making sure we're reaching the right mix of conditions within the company's population. So after we have our roster of members, we want to be able to engage those. And so this slide really speaks to a study that was done, again, on engagement rates and kind of follows up to some of Jess's points. To be effective, we believe strongly that there needs to be an incentive in play, and this study did demonstrate that very clearly. For those companies that had no incentive in place, their engagement rates were pretty abysmal at 4%. The carrot, they were able to drag in more members, but really where they saw engagement rates becoming meaningful was when there was a stick incentive in place. And we'll talk a little bit more about what we're doing in that space. So again, we believe strongly that incentivizing compliance does lead to behavior change. And I think one thing is we all have a vision of what health looks like in our mind. And we think health is a fairly concrete concept, but to the majority of our members it really isn't. It means something different to each person, but what is concrete to an individual is that incentive, be it a premium differential or an HSA contribution, but that's what seems to be working in our populations and seems to be very meaningful to the member. I should mention as well that we do have some companies start in a voluntary model, but we strongly encourage our clients to have a plan for when they would implement an incentive and to work toward that model. So once we've identified the member, we decide how we're going to incent them to participate, then the real work begins, because now we're going to risk stratify members into compliant or not compliant. And in our space where members are doing the right thing, we truly try not to make this a burdensome engagement for them. They're typically going to have limited RN time. Mostly they're going to hear from us by mail with reminders to stay on track with upcoming appointments. They'll receive something that basically says, congratulations, you're doing a great job. Thank you for what you're doing. Here's when we think your next appointments are scheduled, because we want that block of members to stay on track and stay in the compliant side of the line. Our non-compliant members are going to receive more extensive nurse intervention. They'll receive a call or multiple calls at least each quarter. Then we further risk stratify that population by looking at their biometric results, ER visits, inpatient. Claims that would indicate an exacerbation or a flare of their condition are all going to result in them being offered more frequent RN engagement. We're helping them understand what they need to do to get compliant. We're trying to remove barriers for them receiving care. We have the flexibility within the structure of our program to work with members on a monthly basis, a biweekly basis. Some of our new diabetics might hear from their diabetic educator twice a week until they get on track. But again, we're matching the members' need to the appropriate staff skill set. And I think that's been really key. We do have a proprietary system, and this is a screenshot of our current tool, which is actually under major revision. Strictly more from the end user look and feel. The content remains the same. We bring over the health risk assessment information, if I read from left to right, and then each of the conditions has a block dedicated to it, keeping track of those claims dates that we're looking for. Staff are inputting self-reported information, although I will tell you we do operate in the incentivized model on the trust but verify philosophy. So if a member is required to provide an A1C result, we do ask for a copy of that either from the physician office or the member could provide it as well. From the predictive modeling system, we're bringing over care alerts, so things like Betty Jones, you're due for a mammogram, or somebody needs a colorectal cancer screening, or perhaps didn't follow up with their primary care after an office visit. The staff also have access to ER and inpatient stays, so again, that will risk stratify and trigger additional calls to that member. And then toward the bottom of the screen, you see a medication block, and that's where we're calculating the medication possession ratios for each of those meds in the chronic care area. In addition, we also calculate a med possession ratio for any antidepressants the member may be on, because we know how important controlling depression is and making sure people are compliant with medications and with follow-through on their treatment. And in the chronic care space, depression is a very common comorbid condition. So just to talk a little bit about how it works in actuality, the case study today is a client, a manufacturing site, multi-site, U.S.-based, 2,700 employees. Their cost trend prior to 2008 was an 8% annual increase. They became a HealthCheck 360 client in 2008 and a condition management client in 2011. Both programs are incentivized. The wellness program is outcome-based, and I should mention that condition management we consider to be participation-based. I'm not telling anyone, for example, that their blood pressure has to be below 120/80, but what we are saying is they do need to follow through with their annual recommended care, so to participate in their own health as well as taking their medications. So the baseline that you see in front of you is prior to any intervention in condition management, and as you can see, you know, the navy bar would be their actual numbers compared to national average in the green, and so their results were anywhere from poor to mediocre. And interesting to me most when I look at this study is that even today, this is pretty typical result for those clients we work with in the voluntary model. And so as you see how the trend changed for this client once we moved to an incentive, that's the difference in our programming between voluntary versus incentivized. This particular company started out focusing on 3 conditions: asthma, diabetes, and hypertension. And as you can see, we've had great result in moving each of those conditions forward to be significantly better than national average. So in the diabetic compliance area, we moved from 13% as a baseline up to 78% in 14. In 15, we were pretty flat at 79%. Asthma, we moved from about half to 96%. Hypertension, you see a similar story. We had a little bit of a decline in 2014, and when we dug into the information in hypertension, what we realized is that those members who are non-compliant, there was a large core group who have been non-compliant year over year. And so we've been having some conversations around how do we really attack that group. Also would like to mention that to count for compliance, members need to complete each recommended care item. So it's an all or nothing. If I'm a diabetic, I have a list of items to complete each year. If they completed 4 of the 7 or 8, they were counted as non-compliant. This company also raised the bar on the med possession ratio over time. We've started out at 70% and we're currently at 80%. Not a number that we publicize to the participant. When we call and we work with participants, we talk about being med compliant, period. But for reporting purposes, we have raised the bar for members. So a couple of slides now just on costs and what the results have actually been. If you look across from 2007, 2008 to 2014, 15, really they've been pretty flat, which is very unusual in today's world. Average annual growth rate has been 1.57%, and this was achieved despite the fact that their members are 7 and 8 years older. So aging workforce, continuing to maintain relatively flat costs. And also important is that there have been very minimal or no plan design changes made over those years. Another slide looking at various trends. Again, trend has been relatively flat. Client actual is in the navy. National trend is in the green bar. And then the Mercer All-Employee Survey is the third benchmark. So the takeaway really from the study is that the trend is bendable. It's not inevitable that your costs continue to rise annually. Managing wellness and chronic conditions as an integrated approach and an incentivized program does yield savings. And again, we strongly believe that incentives are necessary to generate engagement and ultimately to have a return on investment.
So as you're kind of digesting all this information, we have a couple questions on here that are kind of a good starting point for whether or not you think this might be a good fit for your organization or your client. And so the first one, do I currently have disease management services? If so, do I pay for it? So basically this is kind of self-funded versus fully insured conversation. If you're fully insured, most likely 99.9% of the time, your carrier has integrated that disease management into your premiums, and you're paying for it through your premiums with your carrier. If you're self-funded, typically a lot of times you're going to be paying for it, but that is a separate line item, and so most of the time you can carve that out of your carrier ASO or TPA services and use a third party for that. What reporting am I receiving, and how are they measuring the success or outcomes? So I would ask your carrier or TPA to see the reporting from the services that they're providing with disease management, so you can really gauge, are they just looking at outreach, or are they looking at the impact, the compliance rates, and those items that are being had on my population. And that's going to be able to tell you, is this working or not? Are you partnering with a wellness vendor? So do you have a current kind of well-being strategy in place? What type of program is it? How comprehensive is it? And based on that answer, I think that's going to help you determine if you should integrate disease management with your current vendor, or if you should look at other options on the well-being side. And then once you can answer whether or not you have a wellness program in place or a wellness vendor, is that vendor connecting with your disease management? So, our services with HealthCorp and our condition management, along with HealthCheck, are fully integrated in a seamless level. But a lot of times what you can do is take your wellness vendor and have them send biometric data over to your disease management provider. And so just see if that's an option. See if A, your wellness vendor can do that, and B, will your disease management provider take that data, and what will they do with it? So those are some questions to kind of get you started with everything to determine, how do I gauge whether or not this is working, and does it make sense for me to look at other options in this space? So now I think we are going to open it up to questions.
Yeah, so if anyone has any questions, please type those in the question box in the lower portion of your control panel. We do have a few questions here already, so we'll start off with those, but as you're thinking through and kind of absorbing all the information you've just been presented with, please let us know if you have any questions, and then we'll also provide contact information for everyone if you have any follow-up questions that you prefer to ask one-on-one. But first off, what types of incentives do you usually recommend people employ with a disease or condition management program in this case?
So our employer groups are trying a variety of strategies. I will tell you the most successful strategies, however, are, again, incentivized, but also monetary. So we have a growing block of business that use a premium differential, and we've seen great success in that space. As I mentioned earlier, anything that you keep in front of the employee that says, hey, it costs you $20 or $30 this paycheck, that is certainly impactful. But we have companies trying things like HSA contributions, more on the carrot approach. I have some clients doing co-pays, so you may receive a zero copay for medications in the chronic care category. Those are probably the most common. We're certainly open to others, but strongly believe that really those incentives that hit the member's pocketbook are the most successful.
Okay. So another question, does HealthCheck 360 offer these services?
Yes. So HealthCheck 360 and HealthCorp are under the same umbrella company. And so we do have separate company names, however, have an integrated branding and approach for our clients. And so, yes, we do have a number of clients that utilize the HealthCheck 360 condition management program.
And this question is kind of centered a little bit more around our experience with participants and the programming that we provide. So how do you build DM into a wellness program without the high-risk employees or employees with chronic conditions feeling targeted? Are we seeing DM incentives separate from wellness incentives or combined?
I think the best success model is when they're combined. We certainly have seen them be separate. There's also an integration piece that I don't know that we talked about that relates to both, in that if a member would request a reasonable alternative, certainly we can provide that through the condition management program and perhaps structure their RAS to include additional calls with their RN, which is a win-win for both parties. But certainly I believe very strongly that when we can marry those two up and they follow one another. So in the case study model that we talked about, this is a client that incentivizes all steps of the health risk assessment. So not only doing the screening, completing the survey, having a review of findings call post, then it goes on to encourage and require compliance in the condition management program to receive the full incentive. So I think that combination is a really successful strategy. But certainly we do from time to time see them in a separate model.
Okay. How do you recommend involving patients or participants' primary physicians in these types of programs when they're managing chronic conditions?
Yeah, and I think that's a great question, because I think a misperception on the member part at times is that we're there to dictate what their care is and or get between them and the provider. And that's truly not our goal at all. Our goal is to be supportive of the treatment plan prescribed by the physician. We do have our list of annual recommended cares that are core and key components to our program, but if the physician has another plan for that participant, we just ask for that information from the office, and then certainly we'll accept whatever the treatment plan is as written by the MD. But our role is really twofold, is to help prepare members for their visits, make sure they ask the right questions. It's also to share information with the provider, not that we're offering PHI to the provider, but to do an entree in to make sure we get appointments scheduled. And then, as I mentioned earlier, there are certain elements in an incentivized model that will ask for proof from the MD office. It doesn't need to come directly from the MD. The patient, if they prefer to provide that, we're happy to take it, but we see ourselves as a supportive service to the relationship with the provider, not an adversary in any way, shape, or form.
So how does the integration work if a client has both health coaching and disease or condition management with you?
So really we're going to look at the overview of the participant. If they're that, what I like to term the worried well, meaning they have acceptable biometrics, they're doing fairly, the weight's fairly controlled, glucoses are good, but still have some lifestyle things they want to work on, they're going to be working with the coaches. If they already have a chronic condition, then they're going to come over to the condition management team. And then the systems that we have, actually, we can send messaging back and forth, so wherever the touch point is for that member, there's going to be information available about what each team is needing. So if they're engaged with a coach for a call, there'll be a note that lets them know the person's in condition management and ask for a warm transfer or provides information about what cares they might be needing.
I think the warm transfer and referral part is partly why our engagement rates and compliance rates are so high. Is a lot of times when you've got a carrier calling out and dialing for dollars with disease management, you're not going to see as many people pick up the phone or call back. Whereas if people are required to complete health coaching through their wellness program, our health coaches can say, while I've got you on the line, I know Sue over in condition management is trying to get a hold of you. Do you have a couple extra minutes where I can transfer you over to Sue? Also with that, having this integrated approach and branded, lessens the confusion for participants. So they're not getting calls from Cigna to complete disease management as well as HealthCheck 360 to complete health coaching. And so when we have those integrated services, participants know whether or not they've completed steps in the program versus thinking they did their health coaching call because they talked to Cigna. So it really lessens some of that confusion by having that integrated approach, as well as the other benefits that Chris had mentioned.
Great. We have one question here as well. Are there certain biometric tests you recommend having completed that really kind of round out disease or condition management programs? Things that you don't often see present, beyond the traditional weight, height, BMI, blood pressure.
I think one add-on that's particularly helpful in our world is an A1C. And so for those of you that might not be as familiar with that test, it's a 3-month measure of how well a member is doing with glucose control. Almost every health risk assessment on the planet is going to have a glucose, but that A1C really gives us the sense of it's not just one snapshot, did the member have, a Snicker bar and a latte on their way in, but we truly know what's been happening with that member over a period of time, and it helps us not only enroll the right block of individuals, but it helps us know who has control issues that really require additional RN time. So we certainly think that's a key component to add on.
Okay, great. Well, it looks like that's all the questions that we have for today. If you do have any follow-up questions, all attendees today will receive a follow-up email with links to the presentation recording and contact information for myself and our presenters. This concludes our webinar. I hope you all enjoyed the presentation. In the meantime, keep your eyes open for an invitation to our next webinar and information on our 2017 webinar series. Have a great day.